Hi.
Hello, can you hear us?
Yes,
Okay,
I can.
great. How are you?
I can see we have. I'm okay, thank you. It's really
Oh, what is the
hot, but
temperature
I'm
there?
okay. Uh, I don't even know what the temperature is today. I haven't even checked, but
Right.
it's
What does it
just
typically
really
run
hot.
this time of year there?
Well, about let me see in Fahrenheit degrees. It should be okay. Hold on. Susan, can you hear me?
Yes.
Okay. Um, uh, what time are we starting?
Pearl,
Yeah, I'm here.
hi. Do you want us to share like the file, the document that we're going to be going over, or is it already
Yes,
loaded
please.
somewhere else?
No, I think you need to share it.
Okay.
Yeah.
Okay, hold on 1 second. Can you guys see it?
Yep.
Yes.
I'm trying. Why? Okay, 1 more second. I just want to make sure. I'm trying to figure out why it's not showing in presentation mode.
Not sure why my video is not showing. I can see your screen. I can see the presentation. Did you want to put it in presentation mode?
Pearl, I apologize. I'm having some technical difficulty. I can. For some reason. Okay, let me just try this.
Hello, Susan.
Hi, how are you?
Anything I can help with?
So I have the screen going. I just can't see the participants, but that's fine as long as as we can see the screen, I can hear so we can move forward. Just don't want to
Oh,
hold
okay.
everyone up.
Yeah, I don't think you'll be able to see them. That just focus on that. We can see you though. Just take note.
Okay. All right. Very good.
All right, thanks.
Okay. Then we can begin.
Pearl, did you want to lead us off?
Trying to connect my. Can you hear me?
Yes.
Okay, I was just trying to connect my camera, but I don't know why it's saying it's unavailable now. Okay, good morning, everyone, and welcome to today's session on the social determinants of mental health. The session will be facilitated by Susan Holloway and Alexia Wolf, who are both from Delaware. I'll give them the opportunity to introduce themselves, and I will be moderating the session. My name is Pearl Chunga. I'm from Lusaka, Zambia, and I'm the founder of Walk With Me Foundation. I'll give you a little bit of background on Susan, Alexa, and Aya's relationship. Maybe you can move to the next slide. The next one. The one on. Okay, so Susan, Alexa, and I met during the Mandela Washington Fellowship for Young African Leaders, of which I was a participant in 2019, and they were both my mentors. And when we met, we discussed the differences in the mental health space, both in Zambia and in Delaware and in the US. The fellowship is the flagship program of the US government's Young African Leaders Initiative, YALI, and was established in 2014. We've had over 4,400 young leaders from different countries in sub-Saharan Africa that go to the US for academic and leadership training every year. The Alexia, Susan, and I are partnering on the component of the Mandela Washington Fellowship called the Reciprocal Exchange, which gives American professionals the opportunity and fellows the opportunity to create partnerships and work on a project together for the benefit of both Africa and the US. So we will be working on a project together, which we are targeting creating a sustainable recovery model for Zambia, and the social determinants of mental health are a very important aspect of this project. So I think this will be like a starting point and an introduction, and it will also give Susan and Alexia a good understanding of Zambia and the state of the social determinants of mental health in Zambia. Susan and Alexa, I think you can introduce yourselves.
So, hello. Good morning. My name is Susan Holloway, as mentioned. I work for the state of Delaware, which is in the United States of America. I run our Health Integration and Social Determinants Unit. I'm very excited about partnering and being able to share information that's been successful, for us. We can tell that you're, very excited. We're excited also. And again, we look forward to the partnership. Thank you. Alexia?
Hi, everyone. I'm Alexia Wolf. I am in the Health Integration Bureau along with Susan. And my professional focus has been improving health outcomes in vulnerable communities. My background is in public health. I have a degree in health policy and health service organization. And I'm so glad to be here today and to have had the opportunity to work with Pearl. And I look forward to learning from all of you today as well. Thank you.
Okay.
Okay. We'll just quickly go over, or Pearl, were you going to do this part, or do you want me to quickly go over the workshop agenda?
I can go over it quickly if you like.
Okay.
Okay, so for our session, the morning session is going to be mostly the conceptual framework. So the background, we'll look at a case study of Zambia and the social determinants of mental health, and we'll have a reaction panel. So at this point, hopefully the participants will participate and be active in the session and answer a few questions, and just hopefully give us your insights as well and how you look at the social determinants in Zambia, the state of the determinants in Zambia. From there, at between 10 and 10:30, we'll look at screening for social needs, and then we'll go on the break from 10:30 to 11. For our session, for the social determinant session, because we wanted it to take on the workshop structure where the people in the workshop actually participate and take part in engaging with us and are actually engaged in the conversation. In the afternoon, we'll look at an overview. We'll go back into the session, hopefully with the same participants. We'll have a brief recap on the framework and what we discussed in the morning. And then we'll now discuss an overview of the approach to health integration and social determinants. Have questions, reflections, and reactions from you, the participants. And then hopefully from there, we can co-develop a vision for Zambia. Where do you want Zambia to be, and where do you see us in the next few years? And then from 12 to 12:30, we'll have a debrief on the vision for Zambia. And then from 12:30 to 1 o'clock, we'll have a wrap up, discuss our next steps and future events.
Okay, great. And then if I can, Pearl, just so, again, we want this to be interactive. If the participants, and I do apologize, I can't see you guys, but I know you can see me. If you'd like to introduce yourselves or say anything that that you're hoping to get out of this to make sure that we cover all points, now would be a good time to do that. And if you don't want to do that, that's fine as well.
Okay.
Is there anyone that would like to? I'm sorry?
Yeah. No, I was going to say, is there anyone that would like to give an introduction or say anything?
Okay.
Okay.
Okay, then we'll move forward. And I know we just did introductions, but just to give a little bit of my background. So I've worked in this space and social services for about 22 years now. I have a background in public administration and healthcare policy and finance, and I'm currently enrolled in the process of getting my doctorate in leadership and organizational development. So again, I'm very excited about working with everyone, and we'll jump in. So the overview of the social determinants of health, as you can see, we always say it's shaped by where we live, labor, which is where we work, learn, play, and pray. So historically, health policy was once thought of as being more than a provision of funding and medical care. Like that was the focus at one point. It was considered that if you were caring for someone, that it was all about just the clinical piece of it. And while we do understand that medical care absolutely can prolong survival and improve a prognosis of some pretty serious conditions, disease states, we've grown to realize that another very important part of health for across the populations are the social determinants of health. And we will talk about what those are a little more in depth, but just as a high review, those are the things like housing, transportation, food security, the things that once a clinical need is met, these are the things that individuals need to make sure that they continue to be able to thrive in the community. And then something that we definitely focus on in different places are the environmental factors, which we've learned that they account for about 80% of a population's health. So we're going to focus on the socio-ecological model. And if you see to the right of the screen, public policies at the top, and that falls whether it's under national, state, local laws or regulations, it's always going to govern the system. Then we have the communities. That's where the relationships are built and they're maintained between organizations. And then from an organizational perspective, we have social institutions, which we'll talk about a little bit more in depth. Interpersonal, which is again where we live and where we exist, and that's family, friends, social networks. And then obviously it's the individual, that's the nucleus, that's the person that we're serving, and what we need to be most cognizant about where the care and support system should, excuse me, should thrive. So here, the social determinants of health. So you'll see, again, this is another chart diagram, and in the center, the nucleus is the social determinants of health. But what you see around it, these are all of the systems that go into making sure that people are doing well. So you have economic stability, because if you're unable to work, generate income, and take care of yourself, that's a problem. Education, regardless of what the level is, people need to be clear about what's helping them to stay well. Education, the standpoint of being able to get a job, and education in the standpoint of just being able to navigate different systems. Social and community context, again, we talked about that just a little bit ago. These are what the systems are. These are how the systems are built, what maintains the systems. And then, of course, healthcare, primary care in particular is a big part of the social determinants, because that, again, ensures that people are well and they know what their plans are in terms of staying well. And we talked about an environment and the neighborhood. So again, all of these components work together to make sure that an individual has all the support systems that they need to thrive. So here's another way of viewing it, like the impact of social determinants of health. So we talked about economic stability, and again, it's giving examples of employment, income, expenses, understanding what those are, debt, medical bills, support, neighborhood and physical environment, again, housing, transportation, safety, parks, playgrounds, walkability, zip codes. Again, we'll go more in depth. So this is a pretty high level overview of what you're going to hear as we move through this workshop. Education, literacy, language, childhood education, vocational training, higher education. Again, we'll talk in depth about what each of these things means as we go through the presentation. Food is, food security. Again, hunger, access to healthy options in terms of putting an individual in a position to thrive. Social, community context, social integration, support systems, community engagement, discrimination, stress. These are all factors that play into how people thrive in their communities. And then the health system. We look at what health coverage looks like, access, provider availability, provider linguistics, cultural competency is huge, and quality of care is also a big indicator of how well the community is doing. So another overview of the social determinants of health and health equity. So you'll hear sometimes people use these interchangeably, but I want everyone to be clear that the social determinants of health are a set of conditions for health of individuals, communities, and populations. They're not distributed fairly. If they're not, they can lead to huge inequities. And then health equity is actually what creates an opportunity for us to more broadly think about complex health issues and how to work across many sectors to make sure that health equity is something that's present, because again, that's a key indicator of a healthy community. So SAMHSA, which is our federal organization in the United States that addresses pretty much everything that is associated with behavioral health. So they have a definition of recovery, and I'll just read this since it's in quotes. So open quote, a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential, end quote. So there are four major dimensions that support a life in recovery. Health, which is learning to overcome, manage, and more successfully live with symptoms and making healthy choices that supports one's physical and emotional well-being. 2, home, a stable place to live. It's that simple. Purpose, meaningful daily activities such as having a job, being able to go to school, volunteer or work, creative endeavors, increased ability to lead a self-directed life, and a meaningful engagement in society. And then the fourth is community, relationships and social networks that provide support, friendship, love, and hope. And all of these are equally as, share equal as in terms of being important. And so one thing that we've embraced, and again, we're going to talk more about this, I'm just giving you a high-level overview, is the medical model versus the recovery model. So the medical model, which is obviously incredibly essential, because again, we look at that as the acute phase, as what actually saves someone's life. The recovery model is we consider the function that actually keeps people alive. So it's the ongoing. So we will talk more about how the social determinants of health really do. There's one piece that's obviously primary care that's focused on the medical model, but the other pieces focus on, again, supports that are necessary. I'm not sure how many of you may be familiar with Maslow's hierarchy, but there are certain things that every human being needs to be able to have a meaningful life and thrive. And those are the social determinants of health. Okay, so at this point, I'm going to turn it over to Pearl so she can present the case study and we can walk through that.
Good morning again. Sorry, I was talking and I didn't realize that I had muted my mic. Good morning again. So I'm going to talk very briefly about Zambia, and please feel free to be very interactive and give me your opinions or your views and what you think about our current situation in Zambia. So I know there hasn't been as much research as we would like on mental health and particularly the social determinants in Zambia. But I did come across some crucial information or a few crucial statistics on Zambia and the current place we are with the social determinants. So I know in 2019, the Ministry of Health, together with the World Health Organization, presented a report called The Health Equity and Social Determinants of Health in Zambia. This was in November 2019, and it highlights the importance of social determinants when it comes to health equity and how we can use the social determinant lens to create better health outcomes or to come up with better health outcomes. And in the report, it shows that about 65% of Zambians live on less than $2 a day. And this covers I think, more of the socioeconomic status of the social determinants of health. And in that particular report, the case study that they worked on, the report showed that the social determinants that were most useful to Zambia, so to say, were the socioeconomic status itself, which was a big one because poverty and mental health were seen as sort of correlating factors and major factors affecting health services in Zambia. The age of individuals, their sex, how different genders are affected by different genders are affected by the health sector, employment, occupation, housing, and education. With the education, there's significantly high dropout rates. I think over 60%, again, of our population in Zambia are people below the age of 24. And of this population, about 14% of them have dropped out before their completion of either high school education. So that's a really big gap that needs to be worked on. And then the report also signifies how important it is to use the social determinant lenses to to improve and reduce the gap in health equity. It also says the social justice, it takes into consideration social justice in Zambia and how access to things like safe and drinking water have a huge impact on people's health and mental health as well. Social protection, road safety, housing, recreation, I think came up as well, especially when it comes to alcohol and drug abuse, and how many of these young people, one, are unemployed, two, have dropped out of formal education, so do not have access to actual formal education, and they don't have access to recreation or technical skills training. So a lot of our young people in Zambia end up turning to drug and alcohol abuse because they don't have a sort of balance between finding work and or finding extracurricular or recreational activities. So even in the drug and alcohol report by the Ministry of Health, recreation came up as a big aspect that affects, that leads most young people to drug and alcohol abuse. And another big one, which I think even Walk With Me Foundation has been trying to push an agenda for, is the social support structures. We've got a very poor peer support or almost non-existent peer support system in Zambia. We don't have peer professionals. And I think maybe Alexa and Susan will explain a little bit more on this. There's even the family support structures, I think because of how mental health is perceived in Zambia and how it's looked at, it's a bit difficult for families to accept that they need to be, or they are an important part of the recovery process and they need to be involved in the entire recovery process for this individual to get better. And I will give an example of even just myself or my family. I remember when I went out to get help or to start counseling, a big part for my family was, why are you speaking to strangers about this? We can't talk about our issues to other people outside, without realizing that they're such an important part in helping me to get better and they need to hold my hand through it. And I think this has been very common even with drug abuse and alcohol abuse. A lot of people will look at that person in their family here especially as a rogue, so to say. Not to use it, not to be rude or anything, but that's kind of how they would look at it. And I think this is because we haven't built a culture around strong social support structures for people struggling with mental health, with mental health problems. And we are trying to build, I think, starting from peer support. And I saw in Delaware, and I can see Alexia has said, the peers are one of their strongest components of the recovery service. With peer support, I think our system is very weak. We haven't really gone in depth with that. And I think that's something maybe when we're speaking about building a model for Zambia or a vision for Zambia, it's something that we could go into more details with or more in depth on. Also, the reintegration services and community and family inclusion and support in Zambia has been significantly weak as well. I think we've focused a lot on the medical model, which, like Susan said, is very important. But in comparison to everyone else who's looking at both the recovery and the medical model, we've focused a lot on the medical aspect as opposed to the recovery aspect. And yeah, so this is something maybe we can go into more detail on. I don't know if anyone would like to add anything on the current situation in Zambia or like the current case study of Zambia. Okay, I think the participants are able to use the chat, but only those who've requested to be added on the screen are able to speak. I think right now it's only Ngambo that's requested to speak. So if you have any comments, please feel free to use the chat or if you would like to ask any questions or anything to add on to the current situation in Zambia when it comes to the social determinants. So how, for example, how poverty affects the mental health, or how education, lack of recreation has affected the mental health outcomes or the recovery outcomes. Okay, and unfortunately, I can't even see the participants in the chat. I mean, I can't see who the participants are. I don't know why that is, but yeah. Okay, maybe we can move on.
Okay, very good. Pearl, I would just like to say I'm glad that you talked about and you highlighted the peers. It is going to be a very big part of our presentation. Alexia will speak to that later, but the data overwhelmingly shows that systems that use peers, and peers, for those who may not be familiar, are just individuals with a lived experience who are able to help someone who may be relatively new to understanding all of this navigate the system. Because if you think about it, if you have someone who's already in crisis and they're not doing well, to try to navigate anything, especially a system like this, can be overbearing and just completely. I guess overbearing is a good word to use. And having a peer in place to do that really helps people not only just listen to what should be done or what could be done, they're actually getting firsthand from someone who has actually gone through it. And again, overwhelmingly, the data shows that having peers within systems. And if you think about it, just again from a second, even with the medical model, typically if someone has a certain disease state, they will call someone, whether it's, it could be diabetes, cancer, any other condition. They'll usually call someone in to pair with them to help them understand what resources are available and what to expect while they're going through it. So it's already been in place. It's already, it's been a best practice, but we're just now, when I say now, like within the last, probably 10, 15 years, Alexia can go through. It's really been acknowledged that it's definitely a game changer in the system. So I will go back to the PowerPoint presentation. Alexia, I want this to kind of be informal where people can put in the chat what they're thinking, ask questions. I don't know if you want to add to that now or if you want to wait till later when you're going through your part of the presentation.
Yeah, I think we can certainly talk about the peers in more depth unless people have any specific questions right now. We're happy to respond to those if you want to put them in the chat.
Okay, all right, I will share my screen again. Okay. Pearl, did I miss anything that you wanted to cover? I was kind of flipping through the slides.
No, I don't think so.
Okay.
We covered.
Maybe we can just go through.
Someone in the chat was trying to unmute. So if the audio wasn't working, please feel free to put your comment or your question in the chat.
Okay, so we can, Alexia, do you want to start in? I can turn it over to you about the screening for social needs.
Sure. Yeah, I'd be happy to cover that. Screening for social needs is something that we do for a variety of reasons. As Susan touched on, the medical model, while it's so critical, has limitations. If we only focus on the person's diagnosis and treatment, we miss a lot of important information that will drive their health outcomes if we're not taking a holistic approach and looking at the whole person. And Sir Michael Marmot is really the father of social determinants. And he put it best: why treat people and send them back to the conditions that made them sick in the first place? So if we do give someone a costly treatment and we haven't addressed the underlying issues that contributed to them developing that condition, how effective is that intervention going to be? Next slide. The other advantage of screening for social needs is that it allows us to do something that we like to call meeting the person where they are. Many people with behavioral health issues may not be willing to utilize a traditional pathway to seek treatment, but by meeting the person where they are and hearing from them what their priorities are, it allows us to build a trusting relationship where they might be more inclined to accept treatment. And people with unmet social needs, oftentimes don't have the bandwidth to really focus on treatment because they have to think, where am I going to sleep tonight? Where is my next meal coming from? So if we can start to address some of those unmet needs, it really frees up capacity for the person to start thinking about their recovery and thinking longer term in the future. The social needs are really what allow people to sustain long-term recovery. And in this part of the workshop, we're going to go over the screening that we do with people that we serve, given that this is from an American perspective, but we wanted to share it to give you something to react to as you start to think about screening for social needs in Zambia and what you might want that to look like. And we're starting with housing, which for us is one of the most important issues. And Pearl touched on that in her case study. Housing instability, frequent moving, homelessness, overcrowding, unsafe housing, difficulty paying rent or rent that is not affordable are all issues that get in the way of people being able to focus on their recovery. And oftentimes individuals with unmet social needs are inaccurately characterized by clinical teams as being unmotivated or there are other kind of pejorative labels that are attached to them, when really if the team delved down into the barriers that the person is facing in accessing treatment, they would have a better understanding of what is getting in the way, and the person would have, in all likelihood, an improved prognosis. Next slide. Food insecurity is another big area that we look at. And when we say that, we're referring to unreliable or inconsistent access to nutritious and affordable food. It impacts both the short-term and long-term health outcomes. It creates risk of conditions like diabetes, hypertension, and it can also be related to challenges with transportation, low educational attainment, or limited access to healthy food options. Later in the workshop, when we talk about the approach that we've taken in Delaware, we will share with you about the work that we are doing with a nutritionist from the University of Delaware to offer free nutritional counseling to people in our services. Transportation is another big issue for us. We do have a large rural area in our state, And inconsistent access to reliable transportation can have a significant impact on health and the ability to make healthy lifestyle decisions. It can prevent people from accessing medication, education, employment, healthcare visits, and food. We also look at whether or not the person is able to pay their utility bills, such as their electric or water. If this is shut off, it can often lead to dangerous living environments, unsanitary conditions. We've had situations where people are having major challenges with their utilities and they have young children, and at times they're reluctant to share that information with us because they're fearful that they will lose custody of their children. So that's another area where our peer workforce, because of their shared lived experience, are often able to build that trusting relationship so that the person is comfortable disclosing these needs, and we can work on a plan to address them. Childcare is another area that we screen for. This can impact the health of the child and the caregiver. Inadequate childcare can be a barrier to employment, to medical appointments, and also to educational opportunities. And employment is another big area for us, because it allows people to live in safer neighborhoods, afford better health care, provide education and childcare, buy nutritious food. Unemployment is a barrier to basic needs and is connected with people self-reporting worse health status. Later in the workshop, we'll touch on the disparity among the population that we serve. Almost everyone in our services wants to work, but there is a very high level of unemployment among people with mental health. And so we have a number of initiatives underway to address that so that people can have that dignity of work and have that sense of meaning and purpose. We also look at education to determine if people are interested in pursuing additional education. We know that lower education levels are correlated with lower income, higher likelihood of smoking, shorter life expectancy. And another domain that we look at in terms of social needs is overall financial strain. All of the stressors of day in and day out, struggling to obtain basic needs and to meet financial commitments. It creates a toxic level of stress for individuals. And so connecting people with supports to start alleviating that really puts people on the road to recovery. If you think back to the wheel at the beginning of the workshop with all the social determinants, that showed how interconnected all of these issues are. And we do look at exposure to violence, whether it's interpersonal or community violence, because of the lasting effect that has on the individual's physical and emotional health. One thing that we're starting to focus on, not just in Delaware, but across the US, is how we can better measure recovery outcomes instead of focusing on clinical outcomes. So a lot of the data that we collect is focused on things like reduction in symptoms or decrease in hospitalization. And so we are working together across the country to come up with data measures that better capture the impact of recovery supports, especially in areas like peer support. And so recovery capital is the volume of internal and external assets that can be brought to bear to initiate and sustain recovery from alcohol and other drug problems. And by starting to think about recovery capital and measuring recovery capital, you can start to look at the resources the person would need to initiate and sustain recovery. So if someone has high problem severity or high complexity and they have a low recovery capital, they're going to need a lot more resources than someone with the same problem severity with high recovery capital. And by the same token, if someone has low problem severity or complexity and low recovery capital, even though they have less severity, they will in all likelihood need more resources to initiate and sustain recovery. And the next slide gives some examples of what that might look like. So someone who's employed and has affordable housing they have more internal and external assets to bring to bear in their recovery, whereas someone who may be socially isolated or someone who is being trafficked, would have far fewer resources to bring to bear on their recovery. There is an instrument I'm going to put into the chat called the Brief Assessment of Recovery Capital. And it's a 10-question validated questionnaire that assesses the person's recovery capital. And it measures 10 different domains. As I said, I'm going to drop it into the chat. I'm also going to put a guide to social needs screening just to give you something to react to as the group starts to think about what this would look like for Zambia. And with that, I'll pause in case there are any questions or feedback or comments that people want to put in the chat.
Does anyone have any questions or feedback? Ngambo, you wanted to say something. Do you want to try your audio again? I think I had heard you briefly and then the audio went off again.
Hello.
Hi, yes, we can hear you.
Hi, Pearl. I would like to say that a lot of this is very new, and the reason why I signed up for the workshop was just so that I could get some insight into this particular subject. I'll speak for myself in saying that a lot of it is it's a lot of information, very new information to take in, but I recognize that it's such a big need for me to understand social determinants of mental health, but feeling like I don't really have the resource for that here in Zambia. I'm from Lusaka, Malay counselor. Some of the issues that I've had with some people that I've had the opportunity to relate with in counseling. For example, a family that won't even give a teenager money to go to the hospital because they think that the particular person is exaggerating. And then if there is treatment, that they won't provide the money to buy the drugs because they just don't think that it's something that, is real. But also I was going to say that I find that our religious background also has such a huge impact on us as individuals. When I have had to deal with my own mental health problems, I find that my biggest community, which has been religious, hasn't been the best support for me. I imagine that for a country whose population can be very religious, that's something to look into, because then they will be looking for the kind of support that they need from the group where they feel like they belong. So everything's all up in the air. So many things to think about. But I just want to say this is very new information, and so just trying to understand, and hopefully the afternoon session will be more interactive as we begin to digest all the information. But thank you.
Thank you.
Well, thank you.
Yeah.
Yeah, thank you so much for the feedback and the comments. And if there are any areas where you would like to discuss more or have us go back to, we're happy to do that. And I think it's really the fact that you brought up stigma is so interesting. I think that stigma is really universal, and it's one of the barriers that we face as well when we're developing programs. Because so much of the work of social determinants requires collaboration. Many of these areas to address the social determinants are outside of the control of the treatment setting. So that's one of the great things about what we do, is that we get to collaborate with a lot of different people in different fields, but collaboration can be hard. And the issues that you touched on with stigma can really get in the way of that collaboration if people don't understand mental health issues. And that's one of the advantages of our peer workforce, is that they bring recovery to life, and they give people a different perception than they may have if they have just seen people in an acute phase.
I can actually completely relate, and I think both Alexia and Susan will agree with me that when I did meet them the first time, I was actually really intrigued by all this information, because I felt exactly like that. I felt like it's all so new and like we couldn't do it. But I think if you really delve into it and you really think about it, there's already a lot of work being done in all these different areas, not particularly by the mental health community, but by everyone else. So for example, when it comes to housing, you can look at the community development, the Ministry of Community Development. What work are they doing, and how can they integrate mental health into the work that they're doing, maybe for community development or social security? How can those people at the Ministry of Education who are trying to improve access to education integrate mental health, or consider mental health, or work with the mental health sector to actually improve the mental health outcomes? So I can really relate to what you're saying, and especially when it comes to stigma and working in the community, especially in the low income communities. You find that you feel like, okay, I wouldn't be able to do this in the community. But then if you really delve into it and really think about it, there's all these people that are already doing this work in the communities, only that their focus is not necessarily mental health, but it's definitely something I think that can be done, and something that needs to be done, to be honest. Yeah. But I completely understand where you're coming from, and I think even Alexia and Susan can both tell you that when I met them initially, I was really intrigued by all the information, and I felt like it was so much information.
Definitely, absolutely, Pearl. And I also, I'm just thinking about how far, even in our country, we've come with mental health, and I feel like education has been the foundation for moving forward. Because once stigma is torn down and people understand that, like, mental health it's really no different than if you have diabetes or any, it affects the brain instead of, maybe your pancreas or something else. And then once the stigma's pulled away, to your point, there's a lot of infrastructure already in place, where organizations are helping people in need. And so it's actually, and I don't want to sound Pollyannish, but I think once that piece is taken care of, it's so easy then to leverage all of your resources and pull them together, just adding the mental health component to systems that are already in place. So, we'll talk a little bit more about that later, but I don't want to lose sight that at one point, we're we're doing a whole lot better now, a lot better in this country. But at one point, like we were in the same situation where the church wasn't necessarily supportive. Even like hospitals and places weren't necessarily supportive. But now we're at a place where even our laws speak to parity, where like all disease states must be treated equally. So again, we'll talk about that a little bit more, but I'm glad that was brought up now, because I think it's important that that a lot of systems start this way but have been able to overcome and are actually thriving now, with helping people who have mental health needs. And Alexia, I don't know if you want to add anything to that.
Yes, one thing that comes to mind is that a lot of times Susan and I have started collaboration that may have started out with communication that is stigma based. I'm thinking of like regular meetings that we have in our community with law enforcement and business leaders. Oftentimes their initial communication to us may be stigma based, but we take the opportunity to go to the table with them and start to educate them and to kind of take that to a more productive place. And so I think there are a number of examples where over time we've been able to really develop a productive partnership with people who initially may have had a very limited understanding of the people that we serve.
Thank you, Alexia. Okay. Pearl, did you have anything to add before we go back to the slides?
No, I don't have anything to add. Thank you.
Okay. Oh, I'm not sure why it keeps taking me back. Hold on. I know we're a bit early, I think, for the break. I'm happy to introduce some other food for thought. I mean, Pearl, I'll leave it up to you. We can talk about some other things. I don't know if you want to break this early. We can talk a little bit more about the evolution in mental health and like in this country, if you think that would be of interest. With respect to systems and structure.
So I think something that you mentioned on the collaboration, right? On the club, which is, it's not something that's impossible or not something that can be done, but I think it's just going to be something very new.
Mm-hmm.
Like, for example, if you think about housing here, right? And I'm not sure, I haven't really worked so much or haven't really looked at the housing aspect. If you think about housing here and what work the government or like responsible parties does when it comes to housing, I'm not really sure how much they've done in actually going out and ensuring that people have got access to safe housing and all of that. Now, to think that to get that to from that point to actually get people to realize that, okay, we need to integrate mental health to housing, and the fact that these people don't have sustainable housing or don't have access to safe housing is actually contributing to their negative mental health, is where I don't know how did you approach it? I know like in Delaware we did visit a couple of places that focus on actually during the reintegration in the recovery process, where you help these people, or their peers rather, help them to find housing, and you've got your different departments that help to find housing. But how did you get from that point where you realize that, okay, housing is contributing and we need to work with these other people to ensure that people have safe housing so that their mental health is, their recovery process is also on the positive side? How do you get from that point where, okay, you're just dealing with the mental health on its own and considering now, okay, we need to actually speak to people in housing, or we need to collaborate with people in housing, or we need to collaborate with people in education, employment, and all of that?
Alexi, do you want to try that, or I'm certainly can?
Sure. If Susan, if you want to speak to the integrated recovery,
Yeah,
I think I can also add some work about
absolutely.
our outreach during COVID.
Absolutely. And I'll even go a little bit before that. So historically here, it really took looking at the data. So one thing that you may or may not remember, Pearl, from being here, is that our treatment for mental health basically always includes a residential component, whether
Yes,
it's
yes, I
inpatient
remember
in a
that.
hospital, right, or outpatient. And so looking at the data over time, it became more and more clear that individuals who were housed had better outcomes, because you will go back again if you're in crisis, but yet you're worrying about where you're going to sleep, if you're going to be safe, you can't really focus on getting well. And again, that's with pretty much any disease state, but we definitely saw that in mental health. So in this country, came to the point where like laws started changing around, from an insurance standpoint, around equity and parity and so forth. And that happened because the data was overwhelming. So the recovery model that Alexia just mentioned, we started as a pilot, an integrated recovery model that not only housing, which was huge because it's residential, because we recognized all the social determinants of health needed to be present for people to thrive. So we opened 2 centers in different counties. And so individuals that came in for treatment, again, automatically had housing because it was residential. But while they were focusing on getting well, we did a screening to see if they had job skills. If not, we actually put them through different training programs. We absolutely assigned peers from day one to help them navigate what was going to happen. The peers would accompany them to treatment team meetings, as well as if they were, if they picked up a job, they would become like coaches for them to make sure that they were entering the workforce in a way that was supported, transportation was available. And the outcomes were overwhelmingly positive. Like we will not probably, there is 0 plans to take that model offline because we started as a pilot. And now the care that we look to implement is following that model. And we got such great reviews about it. Lexi and I were asked by our federal government and then another private institution, the Weizmann Institution, to actually talk about how we were able to put this program together. And then even during COVID here, we were able to use the same model and literally help stop the spread of COVID. So, and I mention that only because there are so many externalities, positive externalities, that happen when you put a full-blown recovery model in place. And so, again, if you were to do that, you would start to see, again, so many other, I don't want to call them problems, but challenges start to resolve themselves. Because, again, if you're in a place where you're housed and you're able to get well, then you can either, transition to a lower level of housing that you can actually support. You can, acquire a job. You can get a different level of education. There are so many things that happen when individuals are stabilized and able to be productive citizens that overwhelmingly again, the outcomes of data, it's almost impossible to not acknowledge all the success that will follow that model. And Alexia, I don't know if you want to add something to that, or Pearl, if you have a question, or if anybody else who's watching has a question about that.
I can add about our work on outreach during COVID, when we were able to utilize unoccupied hotels during the COVID lockdown for people who otherwise would have been on the street or in a congregate shelter. So oftentimes with those individuals, when they first accepted services and came into a hotel room, the clinical team would say, you know, this person is very severe, they're going to need a high level of care. But after a short period of time of having a safe place to stay, having regular meals, having a place to bathe, they would say the person is doing so much better. So that is a story that you could start to tell to your stakeholders, you know, that if they make that investment in housing, they are going to see a reduction in things like interaction with law enforcement, using emergency rooms, or other costly interventions for those individuals.
Thank you. Yes, I do. I actually do remember that your recovery treatment always includes residential a residential component, and I think that's where we're on our side we're kind of lagging behind, because even firstly we don't have like a proper in-person recovery treatment center. We have Chinama, but like with my experience, I found that the most that they'll keep someone, even like a drug addict or an alcohol addict, the most they'll keep them is 7 days, which is like the detox, and then they have to go home. And what I found from that going home, that 7 days doesn't really help them much. It just helps them detox. But if you're sending them back home, you're sending them right back to the environment that led them to that place in the first place. So you find that they always relapse, and they'll go back to the same things, the same drugs, the same alcohols, the same unsupportive community. So I definitely agree with you. I think housing or residential aspect in recovery is such an important part of the whole process. And this is definitely where we're lagging behind. And it's something to look at, and it's something to consider. And yeah, I don't know if anyone has any comments or any additions to that.
I have a comment. Can you hear me?
Yeah. Yes, we can.
When you talk about housing and a lack of support from the home environment, one of the things that I'm dealing with lately is because I work with college age, high school and high schoolers and college age individuals. Even when they go to school, for example, instead of it being a positive and healthy environment, it also contributes to just making their mental health problems worse. I'll give you an example. When we talk about when we talk about the housing and overcrowding and all those things, this is something that I'm actually thinking about, how to go about dealing with this problem. One of the girls that I work with, she tells me that at school, some of the issues that the students are dealing with at home, like poor housing and things, overcrowding, child-headed homes, the teachers there use that to ridicule and intimidate them. And I can imagine that for someone who's already dealing with their own problems, which may be made worse by the home environment, that going to school and finding that kind of environment only makes the situation seem even more dire. So when you talk about systems and structure, I am thinking about the school system and structure as well, and how it can help contribute to recovery, especially because we do have the challenge in housing, and the home environment for the low income population. So I do believe that school can be a place where, even when because students spend a lot of time there, that even though they're living a place which may be not so healthy, but that when they go to school, they know that they can find a place which is a little bit more healthy. Teachers who they know, counselors or whatever, support people who they know that they can get a sense of what's the word, support from. So that's something that came to my mind as you were talking about that.
Thank you so much, Ngambo. And that's very true. And I think that's such a big aspect of here, and it's such a big challenge, because majority of the people that we're working with, especially in the low income communities, don't have access to proper and safe housing, and there's the issues of overcrowding and all of that. So I completely agree with you. And yeah, I don't know if anyone else has anything to add. To even when you think about just education alone, and the state the state of education, or like access to education. For example, I've worked with a teenager that's very, 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 very intelligent, and she wants to be at school. But majority of the time, she can't go to school because this term her parents haven't paid her fees. They've got other priorities, or they'll pay for her brothers and not pay for her. And for her, that sends her like into a really bad space, because she doesn't have access to that thing that she really, really wants. So I don't know, like, I think we've got a long way to go, but we need some sort of starting point with the social determinants, especially. And it's a good thing that even the government or Ministry of Health has started talking about them. I think when I was reading that report, the one on social determinants of health, it actually even said it's one of the government's first of its kind, and it was a landmark report for them, because they haven't really done anything like it. And I think we need to move from just having that report in place to actually moving to a place where these policies that they're speaking about are being implemented. But the fact that they're actually talking about it, and we're getting into them realizing that there's a need for more holistic healthcare, is such a huge starting point, and it gives you the room or the opportunity to actually now go out there and start to speak to your stakeholders. Okay, I can see a comment from Rachel. It says, I find this very helpful because I did a course in psychosocial counseling and rapid HIV testing, and my friends and I are having an outreach on Saturday, and we're visiting an orphanage over mental health. Okay, thank you for that, Rachel. Okay, I don't know if you want to add anything, Alexia, or there's any comments. Does anyone else want to add anything else? Okay, if there's nothing to add, I think we can break off early and then maybe come back at 10:30. Or I don't know. What are your thoughts, Alexis? Should we come back, and Susan, should we come back at 10:30, break off early and come back at 10:30, or still come back at 11?
We're totally flexible. So
Okay.
yeah, we're completely flexible. I'm not sure if some people plan their breaks around the time that were published. Times that were
Yeah,
published.
I think so.
Yes, I wouldn't want to change that in case they were making calls or doing something during that time.
Okay, so maybe we can come back at, I don't know. I can see Renaissance is coming on. Yeah.
Yeah, Pupuzianji here.
Hi, Pupuzianji.
Yeah. We can come back as scheduled, even if
Okay.
we take an early break. But I advise that you come back maybe 5 minutes before, just in case anyone wants to interact with you in the networking area.
Okay, no problem. And I think the participants maybe can move to the networking area, or find, if you need to chat with someone, you can meet in the networking area. And then, yeah, like Pupuzanji has said, we can come back maybe 5-10 minutes earlier and see if there's anyone you want to speak with on the side or interact with on the side.
Sure.
Okay, thank you so much.
Okay, very good.
Thank you.
Okay, see you in an hour.
Thank you. See you later.
Bye.
Thanks.
You will all have to leave the session with the top right button saying leave. Including the presenters, yeah.